Welcome to today's discussion on the integumentary system. This is chapter 5 in the Blossom textbook, and the integumentary system represents the first body system or the first organ system that we'll be covering. Up until now, we've been covering those hierarchy levels of complexity, starting with atoms up to molecules, up to organelles and cells, and then tissues. And now we're at our first organ, that is the skin, and in our first organ system, the integumentary system. So let's get started taking a look at the overall arching ideas of this chapter, and that is we're going to describe the integumentary system and its role it plays in homeostasis. Remember, all body systems have a role in homeostasis. We're going to describe the layers of the skin. This is where we're going to spend a lot of our time describing the layers of the skin and the functions of those layers. We're going to be taking a look at some accessory structures of the skin, that is hair and nails and sweat glands. And then we're going to be looking at some of the changes that occur with the integumentary system during the aging process, specifically cancer, and also we'll be looking at a few other disorders and injuries that can occur with the integumentary system. And we'll finish up learning about burns and what first, second, and third degree burns are all about. So that's kind of where we're heading in this chapter. This presentation will cover all of chapter 5. So skin is the largest organ on your body. It's very thin, of course. It covers from 1.5 to 2 square meters in area and has a very huge role, not only in protecting your body, but also fighting off diseases, helping to regulate your homeostasis with your thermal regulation, and has a number of other important functions, many of which we'll talk about now. So let's get into 5.1, layers of the skin. Back in lab 2, you saw skin very, very briefly. And in that lab, what you primarily saw was just to understand what is composed in the major layers of the integument. So even looking at this diagram or this beginning of this video, let's just use this diagram for just a moment to discuss the major layers. Skin, also called the cutaneous membrane, is composed of 2 main layers. One is the epidermis. I'm pointing to that now. The epidermis, recall, is composed of stratified, squamous, keratinized epithelium. And I'm pointing to that layer now. This is the epidermis, composed again of stratified, squamous, keratinized epithelium. Recall that there is a basement membrane. And below that basement membrane, there is the dermis. So I'm pointing now to the dermis, and you learned in the histology lab that the dermis is primarily, not exclusively, but primarily composed of dense, irregular connective tissue. Now, those are the only 2 layers of skin. There's the epidermis, superficial to the dermis. The dermis then sits on a layer of fat referred to as the hypodermis, or the subcutaneous layer. And this layer that I'm pointing to now is primarily, not exclusively, but primarily adipose tissue. This lower area, the adipose layer, the subcutaneous or the hypodermis, is not a part of the integument. It's simply the layer on which the integument sits. If we went deep to the adipose, you would be hitting muscle tissue. So we'll show that to you here in this labeled diagram. So again, the epidermis, the dermis, and those are the only 2 layers of the actual skin. And then below the dermis, there's the hypodermis. And then everything else we're seeing here are accessory organs. Things like hair follicles, sweat glands, sebaceous glands. These are the glands that make oil. Sebum is the name for that oily substance that comes out of some of our hairs. And also, we'll see the erector pili muscles. We'll describe those in a few minutes as well. But throughout your dermis, there are smooth muscles called erector pili muscles. And in fact, every hair on your body surface is attached to one of these erector pili muscles. And this is what allows your hair to stand erect when you're scared. In the skin, there's also a fair number of nerve fibers. Again, the universal color of yellow is shown for nerves. Then the red and blue structures are vascular structures, arteries and veins. And there are different types of sweat glands shown here, and we'll break those down in a few minutes as well. So let's get started with the epidermis. Again, the epidermis is composed of keratinized, stratified squamous epithelium, and there are 4 or 5 layers of epithelial cells, depending upon where in the body this particular epidermis is found. Another thing about epidermis is that it is avascular, does not contain blood vessels. This may seem like just a random fact, but it makes sense. If you gently scratch your epidermis, you definitely are flaking off layers of cells, but you don't bleed. You have to do some significant damage to your epidermis in order to bleed. So it makes sense that there are no blood vessels in the epidermis. Now, I want you to think for a moment, what other tissue, think back to the connective tissues, what other tissue was also described as being avascular, completely avascular? And you may recall that was cartilage. So mature cartilage is avascular, epidermis is avascular. There was one more tissue that was almost avascular. Recall that was dense, regular connective tissue, the tissue that is the building blocks of tendons and ligaments. That is also, well, not completely avascular, but nearly avascular. There is just a little bit of blood flow through that kind of tissue. Now, I said there were either 4 or 5 layers of cells in the epidermis, and that depends on if we're talking about thin skin or thick skin. All over your body, the majority of the skin in your body is thin skin. Okay, and this thin skin has 4 layers, and those layers are as follows. We'll see them better in a moment. From deep to superficial, there's the stratum basale, the basal layer, right? The basal or the basement layer. Then there's the stratum spinosum, the stratum granulosum, very granular in appearance, and then the stratum corneum. Most of your skin from head to toe is called thin skin and has 4 layers, but there are a couple of places where you have thick skin. Thick skin is found primarily on the palms of your hands and the soles of your feet, and in this thick skin there is a 5th layer called the stratum lucidum. Lucid, it's very clear. And we'll see that as we compare thick and thin skin. So let's take a look at this micrograph and compare thin skin and thick skin. In A, we have thin skin. Everything that I'm pointing to down here, all this down in here, this is all dermis. The basement membrane is where my pointer is. The basement membrane is following the pointer, and all of those 4 layers of epidermis are where I'm pointing. And you see there's a relatively thin layer of the outer flaky cells that are called the stratum corneum. In thick skin, there is a much thicker or more layers of cells, and this will be more obvious as we continue. And you also saw this in the lab. But in thick skin, down here, you can really see that dermis, that swirly, whirly, dense, irregular connective tissue. And if we could see better in this picture, we would see that the outer layer is much, much thicker. There'll be other pictures coming along that will make this more obvious to you. Now, the stratum basale is the bottom layer of the epidermis, and except in that layer, all the other cells are referred to as keratinocytes. Keratinocytes. Why? Because they are cells that are making and storing a protein called keratin. Keratin. Keratin is a very fibrous protein. It's kind of collagen-y like, but what it does is it gives your hair, your nails, and your skin their toughness, their hardness, and their water-resistant properties. So you are waterproof largely because of the keratin that is produced by these epithelial cells. And as the layers of epithelial cells move toward the surface, they have more and more of this keratin. By the time you get to the stratum corneum, which is the most superficial layer, the cells have completely died. They've undergone an apoptosis, and the cells are dead, and those cells are constantly flaking off. So the dust in your house, much of the dust in your house, is really you flaking off, right? It's your skin falling off and landing on your TV. So let's go through these layers, starting from the bottom. Stratum basale. Stratum basale. This is the deepest layer, and it is attached down to the basement membrane. Right below the stratum basale, you would be in the dermis. Let's take a look at this picture, and we'll come back and look at this numerous times. So here, the stratum basale is shown in the purple colored cells. It's a single layer of cells. You might describe these cells as sort of being cuboidal in shape. But remember, even though the cells here are cuboidal, this is a stratified squamous epithelium, because by the time you get to the surface, this looks like potato chips, doesn't it? It looks like thin, dry potato chips. And so because these cells are flat, this is a stratified squamous epithelium. In addition to these purple cells, these basal cells, okay, there are also two other cell types that are found here. We'll talk about each of these. The melanocytes and the Merkel cells. Now, these basal cells, there are a number of stem cells down in this layer. So if you cut yourself, these stem cells are able to be regenerated and to form and reform skin. The Merkel cell is a nerve ending. It's a receptor, I should say, for sensation. So this is a sensory neuron. It can pick up sensations, primarily touch. So when you touch your surface of your skin, these cells are able to sense that pressure and are able to send a signal through the neuron. We'll understand how these neurons work far more completely in a couple of weeks. So here we're just seeing this Merkel cell. These are also called tactile discs. Tactile is just a term to refer to touch. So this is a cell that can refer to touch. The second cell that we saw visiting in that stratum basale are melanocytes. These are cells, that produce a pigment called melanin. Melanin is a protein that gives your hair and your skin their color. And melanin is also very important in protecting your epidermis from damage from ultraviolet radiation. If you could see me right now, you would see that my face is very, very red. Yesterday, I was outside for a number of hours, and even though it was largely cloud covered and even rainy for much of the day, I received enough ultraviolet radiation from the sun to really get a sunburn on my face. I am very pale. I do not produce much melanin at all. So again, these melanocytes are cells found in the stratum basale in the bottom layer. So when someone says that a person's skin color is skin deep, in fact, that's not even accurate. Skin color is only epidermis deep. Okay, we all have the same color dermis. The difference is in the melanin produced by the melanocytes, and that color is found throughout and colors the cells of the epidermis. I should say too, while we're here on melanocytes, we all essentially have the same number of melanocytes. So a person with a dark complexion or a person like me who's very pale, I still have melanocytes. The difference is what form of melanin do I produce? So as a very pale person, I'm basically a mutant. I no longer produce a coloring melanin. People with a darker complexion produce more of this melanin. Now, melanin comes in a couple of different types. There's a very dark, blackish brown type of melanin, and then there's more of a tan, Mediterranean sort of coloring of melanin. And it's all about your genetics. What sort of melanin, what forms of melanin did you inherit from your parents? In my case, I inherited a form of melanin that is extremely lacking in color. The next layer up, so stratum basale is the bottom, next layer up, closer to the surface, is the stratum spinosum. Now this is a layer with a lot of spiny protrusions from the cell, and hence their name. Kind of spiny protrusions. And these cells are all held together by desmosomes. Remember, desmosomes are like the rivets, the connectors between cells that hold them together. And the cells here are called, most of them are called keratinocytes, right? Cells that are going to produce keratin. And there's one other type of cell that visits this layer, and that is Langerhans cells. Langerhans cells, named after a guy, Langerhans cells are macrophages. Now, the term macrophage, what does it mean? Macro, large, phage, to eat. These are large, eating, phagocytic, right? They can phagocytose. And typically these cells are wandering around in the stratum spinosum. And if a bacterium or some foreign particle comes down into this layer, these Langerhans cells actually work with your immune system to fight off, destroy that bacteria or those foreign particles. These cells can also help to destroy or clean up damaged cells from some sort of trauma. From the stratum spinosum, which is multiple layers thick, we now move up to the stratum granulosum. As the name suggests, the cells here are very grainy or very granular in their appearance. And this is because there's all those changes happening inside the cell. Remember, these cells, as they move upward toward the surface, are making more keratin. And soon, these cells are going to begin the process of apoptosis, whereby they're going to start disintegrating, if you will. They're going to start breaking down all of their organelles. This is going to be partly through lysosomes breaking down everything. But what gets left behind is the keratin. So these cells are becoming granular in their appearance as the cell is dying off and leaving these clusters of keratin. You can actually see that under the light microscope. Now, stratum lucidum is the next layer, but recall, stratum lucidum is only found in thick skin. And in thick skin, that is the skin of your palms and of your soles, this extra layer is there. Now, stratum lucidum, these cells are dead. They're very flat, and they have within them a breakdown product of keratin, which is a very clear protein, a lipid-rich molecule. So it gives this layer a very lucid or clear appearance, but it also provides an excellent barrier to water. And then finally, we get to the outer, most superficial layer. This is stratum corneum. And these cells are now completely dead, absolutely dead. They have maximum amounts of keratin in them. And you know that if you have a thick layer of skin, you might call that a corn, right? So corneum, corn on the outside. This can be 15 to 30 layers of skin in most places. And if you have a thickened area, a callus or a corn, this can be far more layers of these cells. Now, it takes about a month. It takes about 4 weeks for the cells to go all the way from the bottom up to the top layer. So every month, essentially, you have a whole new epidermis, and it's constantly being replaced as these layers shed off and are replaced from the underlying layers. So let's go back up and just take a look at the medical illustration of these layers. Here we go. So again, on the bottom, up against the basement membrane where my pointer is, we have a single layer of cells. It's the stratum basale. And in here we have two visitor cells, the melanocytes and the Merkel cells. Then here in the stratum spinosum, this thick layer, these are healthy growing cells. These cells are undergoing mitosis. They're dividing, they're growing, they're very, very happy cells. Remember, epithelial layers are avascular. So where are these cells that I'm pointing to? Where are the cells in the stratum spinosum getting their nutrients? Where are they getting their oxygen? And the answer is from the blood vessels down in the dermis. Now, they're not shown in this particular picture, but the blood vessels down here have the oxygen and the nutrients, which are then having to permeate through diffusion, going from an area of higher concentration to an area of lower concentration, supplying everything that these cells need. These cells continue to be pushed upward, and they make their way to the next layer, the stratum granulosum. Again, you see the granular appearance that the artist has put in here, and under the microscope, you will see a granular splotchy appearance in these cells. Then, in this picture, green, the stratum lucidum, this is the layer only found in thick skin. It appears clear or lucid, translucent, under the microscope. And then finally, at the top of the epidermis, the most superficial layer, is the stratum corneum. 15 to 30 layers of cells typically, and it can be much, much thicker, especially on your soles and your palms and any place where you have calluses. And these are the cells that are constantly flaking off into the atmosphere. Okay, so that is an introduction to the layers of the epidermis. Let's now go to the dermis. Now, the dermis is the deeper layer of the skin, and it is where all the business of the skin is. This is where the blood vessels are, the lymphatic vessels, the nerves. This is where the hair follicles and the sweat glands are primarily found. Some of these things do permeate up, like the sweat glands and the hair, into the epidermis, but their base, the majority of their structure is down here in the dermis. And recall, the dermis is composed of dense, irregular connective tissue, and that irregular matrix of collagen is what is holding all of these structures into their proper place. As a dense, regular connective tissue, and as a member of the connective tissue proper family, remember that fibroblasts are the main cell that make up the dermis. So looking at this lovely layer, lovely picture, what we're seeing here is skin. At the very top, this is the epidermis. So the basement membrane, and this is more in line with what you saw in lab, the basement membrane is where I'm bringing the pointer around. And so everything above the pointer is epidermis. In fact, let's go ahead and name those layers. This is thin skin. So this is only going to have 4 layers in it. But let's take a look. Right here, where my pointer is, this is 1 layer. This is the stratum basale. Then there's a layer, quite a few layers thick, of happy, mitotically active, metabolically active cells. This is the stratum spinosum. And then we see this granular layer, kind of gets darker. This is the stratum granulosum. And then above that, we have these flaky cells, dead flaky cells up in the stratum corneum. Okay, so that's a nice visualization of the layers of the epidermis. Down here in the dermis, we have that swirly whirly look. This is that dense, irregular connective tissue. This particular micrograph is also pointing out that the dermis is composed of 2 layers. One, the more superficial layer, is the papillary layer. Now the papillary layer is the part of the dermis that interconnects with the epidermis. And you see that the basement membrane is not flat, right? That there's an up and down, peaks and valleys, where the dermis and the epidermis interlock together. This interlocking region of the dermis is called the papillary layer. And recall, papillary or papilla is a term meaning nipple-shaped. Now that may be a new term for you. We're going to see lots of papillary structures in this course, but papillary means nipple-shaped. So we see these interdigitated nipple-shaped projections from the epidermis down into the dermis. The majority of the dermis is called the reticular layer. Recall that reticular means network. So this is a overlapping, all those layers of collagen that are densely and irregularly packed down here are holding all of those structures of the dermis in place. Also lots of blood vessels down here. Lots of blood vessels in the dermis. So I just mentioned the papillary layer is the more superficial layer. Now, in the histology presentation, I said that there was loose areolar connective tissue kind of all over the place. And there's a couple of places where you can point and say, there is a concentration of that areolar connective tissue. And one of those places is here in the papillary layer of the dermis. Again, fibroblasts are the cells that are making this arrangement of proteins. There's a few fat cells in here, but there's also a lot of blood vessels. These blood vessels are the ones that are going to vasodilate or vasoconstrict to help regulate your body temperature. There's also here in the papillary layer a few more nerve endings called Meissner corpuscles. Now, I'm not going to get too much into the nerve endings of the skin. When we get to the nervous system and we are talking about how the sensation of touch is generated, I will then come back and we'll dive in just a little bit more about the different types of receptors found in the skin. There's 5 or 6 different types of nerve endings in the skin. So I'm just pointing out that they belong here, but I'm not going to have you name them. So you can basically ignore this term, not to be memorized now. As we go deeper into the dermis, we get to the reticular layer. Again, this is the layer that is thicker, and this is where you find that dense, irregular connective tissue. Very vascular, lots of blood vessels, lots of nerve endings. And there's also a fair amount of elastin produced by the fibroblasts down here that's going to allow skin to have its elasticity, its ability to sort of stretch and recoil back. There's also a fair amount of collagen in the skin that's going to give it its strength. And if we take a look here, this is essentially a repeat of the previous picture, except this particular picture highlights the papillary layer, the more superficial layer of the dermis, the reticular layer being the deeper, larger area. And we see that there's just a rich blood supply throughout the dermis. Again, notice no blood supply up in the epidermis. Now, briefly, let's just go to the hypodermis. This is simply the layer on which the skin sits. This is also called the subcutaneous layer, right? Sub, under the cutaneous membrane. And you'll also see this same layer called the superficial fascia. This term doesn't make sense yet. It will in a few days when we get to muscle and structures of the body, muscle and other structures. But for now, we won't worry about that superficial fascia, but later on that will make more sense. Again, hypodermis, not a part of the skin, but is always shown and is certainly connected to the skin. Down in the hypodermis, two things. Adipose is the primary tissue, but you also find more of that loose areolar connective tissue. So that loose areolar connective tissue, there's a nice little layer of it in the papillary layer of the dermis, and there's also a fair amount of it in the hypodermis. So if you're looking for a place mentally to place that particular type of tissue, papillary layer of the dermis and hypodermis are the two go-to places. So I've already mentioned that so we're done with the layers, right? We talked about the epidermis, the dermis, and the hypodermis. Now let's go back and pick up a few more details. I told you that your skin color is influenced by pigments, specifically and mostly melanin, and that melanin is made by melanocytes, and those melanocytes are found down in the stratum basale. So here again are the stratum basale cells, those basal cells. Here is a melanocyte, and the melanocyte is releasing little packets of color, right? These little melanosomes. So zome is a body-like structure, a little capsulated, almost like a little vesicle filled with melanin. And those little capsules of melanin, as you can see, are being released, and they're carried with the cells up through the epidermis. So a person with a darker complexion is producing melanin of a darker color, and a person with a lighter complexion is producing less melanin and likely also a melanin that has less color in general. Again, we all have the same number of melanocytes. It's just what are they producing? Now, this melanin, like I said before, protects us from the exposure of UV radiation. So think about it for a moment. Where are most people historically who have darker skin tones, darker complexions, where are they historically found in the world's map, right? On the world map, people with the darkest complexions are found closest to the equator. We think African, dark complexions. Then let's go away from the equator and let's move to, for example, the Mediterranean areas, right? Mediterranean and some of the South American regions. And there you start in the Middle East, and you start thinking about folks with sort of a more of a tanned or a Mediterranean complexion, not as dark as African, but still clearly a darker skin tone. And then where do you find people with little to no skin color? And they are at the poles. They are Scandinavians and folks who live in the away from the equator, from toward the poles. And where would you expect there? Well, let me ask this: where would you find the greatest number of people with skin cancer? Where is the highest rate of skin cancer? And worldwide, one of the hot spots for skin cancer is Northern Australia. Think about it in the map. Northern Australia is closer to the equator. It's a very tropical place. Yet, the people living there for the last 200 or 300 years have been displaced Europeans. So very, very light complexion, but they're living in a tropical place. And as a result, their body does not make the darker melanin. So their skin is more prone to the damage that comes from UV radiation. And there's a much higher rate of skin cancer as a result. Now, the negative side, if you have very dark melanin, very dark skin, that dark skin can interfere with the production of vitamin D. Now, vitamin D is formed, the first step in the synthesis of vitamin D in our body is the UV radiation coming into the skin. And people with a very dark complexion have less vitamin D. Now, vitamin D is an important metabolite, and individuals with darker complexion usually need to be concerned about their vitamin D production. So that darker melanin, right, makes it more difficult for the skin to get burned. Not impossible, but definitely darker skinned individuals can get sunburns, but they are certainly more protected than those like me with more pale skin. Another thing that the sun can do, too much sun exposure can lead to wrinkling, which is basically caused by a breakdown of the dermis. And the dermis, basically the dermis is also responsible for our fingerprints, right? The up and down sort of ridges that you see on your fingertips is the interaction between the epidermis and the dermis. Now that's a completely random event. Identical twins, even though they have everything else genetically the same between them, do not have identical fingerprints. So your genetics do not determine your fingerprints. Your fingerprints are just a random arrangement between the dermis and the epidermis. Lastly, too much sun exposure can lead to cancerous changes, mutations in the dermis and the epidermis, and this can lead to skin cancer. So skin cancer is basically it's a genetic condition, right, where the cell cycle has been interrupted in the cells in the epidermis typically. And when you hear about skin cancers, you'll hear about basal cell carcinoma or other types of skin cancer. So I'll show you those when we get to the end of this chapter. We'll talk about that. Oh, one more thing though, while I've got this picture up. Irregular accumulation of melanocytes in the skin can lead to freckles. And freckles are usually more obvious in some individuals in the summer months. Those irregular masses of melanocytes, if they're very large, can appear as a mole. So a mole is just a large group of melanocytes, usually are benign, but these groups of melanocytes with increased increased sun exposure can become cancerous. So it's very important to monitor moles. If you have moles in your body, every year when you go for your annual checkup, you should have those moles checked. Make sure they're not changing. We'll talk again about that at the end of this chapter. And there are conditions whereby the melanocytes produce varying amounts or differing amounts of melanin, and that can lead to a number of conditions where the hair has, if you will, white patches, or where the skin, vitiligo, where there are areas where the skin has less melanin produced. So that brings us to the end of 5.1 and the layers of the skin. Let's move on to the accessory structures of the skin. And let me tell you, this is an area where I'm going to introduce some basic ideas. I am not, however, going to have you labeling the parts of a hair follicle, or labeling the structures of a fingernail, or labeling the minute structures of a sweat gland. Okay, so I'm going to just mention them. What I mention is what you need to know, but other structures within here, you do not have to worry about labeling something like this. Here's what I want you to see. Down in the dermis, this is for a hair. The hair is referred to as the hair root, the bottom part, just like a plant, right? The root of the hair. There is a bulb structure down here, and there are blood vessels that come up and feed that hair. There's also nerve endings that come up and are attached to that hair. So if you pull a hair, it hurts, doesn't it? It hurts because there are nerve endings that are being disrupted at the base of that hair. Also, there are melanocytes down here in the base of the hair, down here in the papilla, that little nipple-shaped extension that goes up. There are some melanocytes. Those melanocytes are what give your hair its color. Again, those melanocytes are different than the melanocytes in your skin, and they provide you your hair color, which also is genetic. So you could have hair that has very little color, blonde, or you could have brownish hair or black hair or red hair. All of those differences are from the melanocytes and the type of melanin found in the melanocytes of your hair. So again, all these details through here I'm not worried about. I will say that each of your hairs is connected to a smooth muscle called an erector pili muscle. And this muscle is going to pull, contract in response to signals, typically when you're scared, right? And that pulls your hair to stand up. Now, the other thing that can happen is when you're cold, you can get goosebumps, right? And that will help you with trapping some air for insulation. But typically we think of erector pili muscles pulling when you're scared or when you're cold. Hair growth. I am not going to worry about the 3 phases of hair growth. So I'm going to put a block right here or put a blue area through here. Don't worry about those stages. Hair does grow, though, at about a rate of 0.3 millimeters per day. So we all know we have to go to the barber or the stylist every once in a while and get our hair cut. Hair is growing. And on average, we're losing about 50 hairs a day. And we're replacing those 50 hairs. So there's an equilibrium. So we lose as much hair, or we gain as much hair as we lose. If there is excessive hair loss, we call that alopecia. Alopecia is the loss of hair. Now, this can happen from a number of things. It can happen from just normal aging. It can happen from dietary changes, hormonal changes, radiation exposure, right? People who have had chemotherapy will lose their hair and undergo an alopecia. That hair oftentimes, most often, comes back. Dietary changes can change your hair and can lead to hair loss. Some people after, for example, a gastric bypass, and they have significant restrictions in food following that surgery, will undergo a period of alopecia. Hair color, as I already mentioned, is formed or caused by melanin, melanocytes, down in the hair papilla. And we have different types of melanin, again, genetically determined from your parents. Over time, what happens? Just like most other things in our body, as we get older, the melanin production in those melanocytes decreases, and that will lead over time to a lack of color, and the hair becomes gray, right? That's a great reduction in the melanin. And white hair, pure white hair, is an absolute lack of any sort of melanin being produced. Nails, another accessory structure of the integumentary system. We know we find this at the tips of our fingers, the tips of our toes. There's only a couple of things that I want you to know about nails, and do not worry about these structures. Okay, so I'm not going to worry about any of these structures of nail. I do want you to know, though, that what forms the hardness of your nails is keratinocytes. The same protein that produces your hair, keratin, is also the main protein that forms and is the foundation of your fingernails. And then we get to sweat glands. This is the third and final accessory gland of the integumentary system, and there's a few different types of sweat glands. We have sweat glands that help us cool our body. We have sweat glands that produce an oily substance that keep our sweat glands or keep our skin moist as well. So let's talk about the kind of sweat gland first that releases good old normal sweat. And this is the sweat that's released when you're exercising or when you're hot. This is regulating your thermoregulation. These sweat glands, the eccrine sweat glands, what they're doing is primarily producing water. They're found in greatest concentration in the palms of your hands. We all know our hands are sweaty. The soles of our feet, right? We sweat a lot into our socks, and we certainly perspire a lot from our forehead. These are basically little, you see the little sweat gland here, and you see this wound up tube that goes up to the surface of the skin, and there are little pores up here where the sweat is released. Notice that these eccrine sweat glands are not associated with a hair. They just go straight up to the surface of the skin. Again, a lot of these suckers in your forehead, palms, and soles of the feet. Now, apocrine sweat glands. We've seen that word apocrine before. Remember, apocrine was also a method of release. Apocrine, remember, the apical portion of the cell was pinched off as, for example, breast milk is produced. Apocrine sweat glands are found in the armpits and in the genital region. So these are the places where we have terminal hair following puberty. This coarser terminal hair is under hormonal control, and these sweat glands empty usually along a hair follicle. So where the hair of the armpit and the genitals are, these sweat glands come up alongside those hairs. Now here's the difference. In addition to the normal water and salt that's produced in regular eccrine sweat glands, these apocrine sweat glands also produce some organic compounds. They make this sweat thicker, and after we sweat this kind of sweat from our apocrine sweat glands, the bacteria love to break down these extra compounds that are produced by these sweat glands. It's the bacterial breakdown of this sweat that causes that lovely smell, right? So if you have a 11-year-old kid in your car who just played 2 hours of soccer, they usually don't stink too bad, right? They sweat, but they don't stink. You put a 14 or 16-year-old child into a backseat of a car who's been playing soccer for a couple of hours, and you know that they stink quite differently after puberty. And that's because now these apocrine sweat glands and that pubic hair and that genital hair is now formed. Most antiperspirants, right, are using active ingredients to stop the sweat. So antiperspirants stop the sweating. Deodorants simply cover up the smell, right? That's really what's going on here. Then the third type of sweat gland are sebaceous glands. These are glands that are producing an oily-like substance. They're found all over the body. That oily substance is released. It does help lubricate and waterproof the skin and the hair. Sebaceous glands are, I will say always, although it says most, but everything I've ever seen, they are associated with hair follicles. So as mammals, we have hair from head to toe. We have hair, even where we don't think we have hair, we have microscopic hair. And these sebaceous glands release those products to the surface of our skin, and that oil that they produce is called sebum. And that sebum keeps our skin lubricated. As we get older, our sebaceous glands don't work as well. Our skin, as a result, gets drier. So as we get older, right, many people are putting more moisturizing cream on their body because they feel very, very dry. And that brings us to the end of the accessory glands. Make sure you go back and just focus on the few details that I mentioned about for hair, nails, and the 3 different types of sweat glands. Moving on to 5.3, functions of the integumentary system. I think this makes total sense, but there might be a couple of things in here that you haven't thought about related to skin. Number 1, the skin protects us. Clearly, the skin protects us from wind and water, from UV radiation, acts as a barrier. Those keratin layers in our stratum corneum give our skin sort of a tougher waterproofing component. And we have that sebum that also is keeping our surface of our skin kind of moist. The skin also acts as a barrier against bacteria and other chemicals that might come into our body or try to colonize on our body. And also sweat in its very nature actually produces some chemicals that act like an antibiotic and actually help reduce the number of bacteria on the surface of our skin. The skin is full of nerve endings, full of them, right? There are nerve endings in our epidermis, in our dermis, and our hypodermis. Each of these nerve endings detects different things. Some of these nerve endings detect light touch. When you feel sheets that are rough or silky, how do you tell the difference, right? How do you tell the difference between coarse and rough, or different kinds of sandpaper, right? There's very coarse and fine sandpaper. All of those tactile touching differences come from the nerve endings in your skin, especially a large concentration of those in the tips of your fingers. Then we have other types of nerve endings that respond to vibration, others that respond to twisting of the skin or deep pressure, like pushing down hard. And then there are some that respond more to light pain or hot and cold sensations, right? So each of these different types of nerve endings, which I'm not going to focus on here, I'm instead going to focus on when we get to the nervous system. You might be asked to label something in mastering about these different nerve endings, but I'm not going to hold you to them in or on this test related to the skin. So in these micrographs, right, they're pointing to these structures and pointing out that some of these nerve endings are very high up in the dermis. In fact, what part of the dermis are we in? Just quiz yourself. What part of the dermis are we in here? Are we in the papillary layer or in the reticular layer? And I hope you're saying the papillary layer, right? The papillary layer is this interdigitated region. It's where the dermis and the epidermis kind of fold up and down these peaks and valleys. Whereas everything down here, just as a review, this would be the reticular layer of the dermis. This is also a good place though to show you something else. This is thick skin. Thick skin. I know it didn't say that anywhere, but what we're looking at here is the stratum basale. The stratum basale, we're looking at the epidermis again. Stratum basale is a one layer of cells at the bottom. Then there's a nice pink layer of stratum spinosum. Then you can see the dark layer. That is the stratum granulosum. And then, for the first time, you can see there's a very thin layer that's lighter in color. That is the stratum lucidum. And then you see a very thick layer of the stratum corneum. So this would be on the fingertips, the palms of your hand, the soles of your feet, and you would have a much, much, much thicker layer of the stratum corneum. Again, at the surface, you see flaky cells as they flake off into the vacuum cleaner. Another really important function of the skin, we've already touched on it, is thermoregulation. You all know that when you're hot, your skin gets more ruddy, more red in color. You sweat more. What's happening is that the blood vessels closer to the surface in the dermis are vasodilating. They're opening up. They're releasing heat. When you're cold, the opposite happens. When you're cold, those same blood vessels vasoconstrict. They shut down. Your skin color becomes more pale, and your body is trying to conserve heat by holding it in. You can sweat a lot, right? So if it's a hot day, you can really sweat a lot of fluid per hour. And this can be much higher if you're really actively working out. But even just walking around on a normal day, you're losing water constantly through evaporation of your sweat. So here in the picture, we're seeing the blood flow. And again, if it's a cold day, the blood vessels toward the surface of your skin are not receiving much blood. They sort of shut down. And if it's a hot day, the blood reaches higher up. Circulation goes closer to the surface. Some of that heat is released, and you lose heat and try to cool off the body. As we age, the skin, a couple things happen. Of course, I mentioned that the sweat glands stop producing as much, so our skin gets drier. In addition, the fibroblasts that are making the collagen just don't do as good a job of laying down the collagen. And so the collagen production decreases, the elastin protein production decreases. This leads to thinner skin that is not as strong and is not as elastic. And then finally, within the skin, our Langerhans cells, there's fewer of those. And so we have lowered immunity function as well when it comes to this. Finally, if you've visited elderly people, you know that they really struggle with thermal regulation, right? Grandma may always be complaining about being hot or cold, because her integumentary system, the blood vessels, and all of the components that we've been talking about are not as well oiled, and as a result, they're not able to maintain body temperature as easily. With age also comes the less ability to make vitamin D. Vitamin D is an important component in your bones. We'll talk about vitamin D more when we get to the skeletal system. And if your skin is not as healthy, or you have a complete absence of sun exposure, a lack of vitamin D production by the body can lead to a condition called rickets. Now, we don't see this anymore in the United States or in most of the world, and the reason is, even if we don't have much sun exposure, most of our dairy products have been supplemented with vitamin D. So you can live in a completely dark environment, and as long as you're drinking milk, you're going to get some vitamin D, which is going to prevent this condition called rickets, which is where there isn't enough calcium absorbed in the bloodstream. So we don't see this anymore, at least not much in the developed world. There's still plenty of rickets in parts of the world where they don't have milk supplementation. Finally, lower levels of vitamin D, typically with aging, can lead to a weakening, a softening of the bones. This is called osteomalacia. Osteomalacia is a softening of the bones. Again, we don't see it very much because we have vitamin D supplementation. Vitamin D is also very important in our overall immunity, and we certainly heard a lot about vitamin D during COVID, during the COVID pandemic. There was evidence that vitamin D was one of the things that was shown to be in lower amounts in individuals who were hit more with the COVID infection. People with adequate levels of vitamin D had fewer COVID side effects. So something about vitamin D certainly is connected to the viral load or the symptoms that were seen in COVID infection. That's the end of 5.3. Last section, 5.4. Let's go through some of these diseases. We'll start off with skin cancer. Skin cancer, one of the most common types of cancer, but there's a couple different types here that I want you to hear about and know about, and you now have enough information to better understand what's going on. You know that cancer is caused by a disruption in the regulation of the cell cycle. This disruption is oftentimes from exposure to UV radiation over many, many years. That UV radiation leads to genetic mutations in our skin, and the mechanisms of the cell cycle can be hijacked. A couple different types of cancer. One is basal cell carcinoma. Basal cell carcinoma. Well, you already kind of know exactly where it's starting. It's starting from the basal cells. So this is a cancer that is forming from those cells down in the stratum basale. It's the most common type of cancer, of all cancers, and the most common type of skin cancer. And it's found typically on the body where there's more sun exposure. The great news about this, though, is that it is quite treatable if it's caught early. Okay, it tends to grow, but they respond to treatment very, very well, either by surgically removing or freezing off those cancerous lesions. So basal cell carcinoma, very common, but very treatable, which is why you should definitely have a doctor looking carefully at places that you can't see, the back of your neck and shoulders and behind your ears. Those are places that you can't even see yourself. Don't worry about recognizing them. Just know basal cell carcinoma is from the basal cells in the stratum basale. Squamous cell carcinoma, you also know where these are coming from. These are coming from the keratinocytes in the stratum spinosum. Again, found on the scalp, ears, and hands. Second most common type of skin cancer. And this type of cancer is more aggressive, and if not removed early enough, can metastasize. So this one's of greater concern, right? Squamous cell carcinoma, definitely something that needs to be taken care of because it can metastasize to different parts of the body. The type of skin cancer that you do not want to hear that you have is a melanoma. Melanoma is a very aggressive form of skin cancer. Typically, melanomas develop from a mole. Remember, moles are clusters of melanocytes. So these melanoma cancers are cancers of the melanocytes. They're the most fatal of skin cancers. They are highly metastatic, and Oftentimes, by the time they're found, if they grow at all, they've already metastasized before the person is aware that it's a problem. So big deal, big problem. People die of melanomas, and what you're seeing here basically are moles, right, that have gotten very weird. So the rule of thumb is this: if you have a mole or any sort of patch on your body, and you see any of the following changes, A, B, C, D, E, mnemonic, you want to get into your doctor as soon as possible. And don't just call your doctor and say, I think I've got a spot on my leg or on my hand or on my nose. And you want to say to them, I'm noticing some changes. And here's what you want to say to them: I'm seeing a change in the symmetry of the mole. I'm seeing that the borders are becoming irregular in their shape. I'm noticing a variation of colors within it. I'm noticing that the diameter has increased and that it certainly is evolving in its shape. Those are the signs that your little old mole that used to be round and uniform is significantly changing, and those are very serious things. In addition, sometimes you'll see, is it elevating? Is it getting harder or firmer to the touch? And is it growing larger? So again, lots of just letter mnemonics to help people remember, if you see these changes occurring, especially in a mole, to reach out very, very quickly to your doctor or dermatologist. What are a couple of other relatively common skin disorders? We probably have all dealt with acne. I'll talk about that in a minute. The other one is eczema. We hear about eczema on TV. You may know some people with eczema. So let's talk about eczema first. It's basically an allergic reaction. It's dry, itchy patches of skin. It can look like a rash. For some people, it's a hypersensitivity, and the individuals are actually having sort of a self autoimmune disorder against dust mites. Others are just some sort of allergy of sorts, and individuals have to use creams to keep it more moist, corticosteroids to keep the inflammation down, and some patients also go on immunosuppressants. You hear about these psoriatic arthritis type of things as well, sort of all related in a way. So individuals with eczema have large, rashy, dry areas, but it's not just a regular rash. Then we get to acne. We probably all dealt with acne in one way or another. Your skin, especially during puberty, has a large number of those sebaceous glands. Remember, sebaceous glands are releasing sebum. Remember also that they are releasing their products via holocrine secretion, so they are releasing the entire cell with all of its debris through the pore. They get clogged up, and that leads to a buildup of acne. So acne comes in two basic flavors: whiteheads and blackheads. What's the difference? Here is a hair follicle on the left. Here is a sebaceous gland. That sebaceous gland is now releasing a lot of its products, and oftentimes that can get some bacteria down in here, can cause this to get red and swollen. And if all of this is underneath the surface of the skin, then this is a whitehead. If that product makes its way to the surface, breaks through, then the product gets oxidized from the environment and it turns it black. So a whitehead and a blackhead, right? They're both the result of overactive sebaceous glands that lead to lovely things on our skin, especially during our teenage years. The last thing I want to talk about when it comes to skin are burns. You know that if you cut yourself, your skin heals very quickly. You know that those stem cells down in the stratum basale go to work and the layers are replaced very quickly. But let's talk about what happens when a larger area of your skin is affected referring here to burns. Burns can be the result of heat, right? Radiation from the sun, sunburn, but it can also be more significant electrical burn or chemical burns. When there is a death of skin cells, there's all sorts of things that go on that can follow, and burns can actually cause death if there is a large enough region of the body that is covered by this. Also, when you lose your skin layers to a burn, you also open your body up and make it more susceptible to infection. So you have all sorts of reasons why a significant burn is very dangerous and can be a life-threatening condition. First thing I want to introduce to you is the rule of nines. It's just a simple way to add up the percentage of the body that is affected by a burn. So a patient has been in a house fire. A patient has been in a car accident where there was heat and they have suffered burns to their body. We can quickly determine what percentage of their body has been affected by the burn by looking at the rule of nines. So if a person has burns across their upper thoracic region, right, thoracic upper abdominal region, that's about 9%. If it's around the umbilical region, right, the lower abdominal region, that's another 9%. Both from the front, 9%, back, 9%. Abdominal pelvic region, 9%. The buttocks, another 9%. Front of the leg, 9 each leg. Back of the leg, 9 each leg. Arms are smaller than legs, so they're only 4.5 on each side. The head, 4.5 on the front, 4.5 on the back. Again, this is just a general, easy way to approximate the percentage of the body that has been affected by a burn. The higher the percentage of area, the greater the chance of death from the burn. Let's go through the kinds of burns. They go from least to most significant. First degree burns. First degree burns is the most superficial. It's what I got over the weekend. It is only affecting the epidermis. This is your classic sunburn. The skin's a little bit painful, a little swollen, but it will resolve in a few days. That is a first degree burn. The only thing that's been affected is a part of the epidermis. In a second degree burn, the damage goes deeper, and it is going to affect all of the epidermis and is going to go down and damage portion of the dermis. These burns, second degree, are very swollen, and what is most telltale about a second degree burn is the presence of a blister. So if the skin blisters, it is a second degree burn. Think touching a stove, you get a blister. Think touching a curling iron to the forehead, you get a blister. You can get a second degree burn from sitting in the sun too long. I have in the past gotten very large blisters on my skin just from being in the sun for a couple of hours. So second degree burns can absolutely cause a second degree, or sun can absolutely cause a second degree burn. Third degree burn. This is all of the epidermis is destroyed, and it goes down and destroys all of the dermis as well. It goes down, it destroys all the nerve endings and all the sensory functions of the skin. These are the most serious. They can appear all sorts of different colors. They require immediate medical attention. And some books will even talk, and this one does, about a fourth degree burn. A fourth degree burn is simply a more severe third degree burn where you actually are exposing muscle or bone. Here's the thing to remember about third degree burns. Third degree burns do not hurt. And the reason they don't hurt is because in this burn, you've destroyed all of the nerve endings. Now, third degree burns are called full thickness burns because you have gone through the entire skin. You have burned through all of the epidermis and all the dermis. Because you've gone through all of the skin, there are no more stem cells present to repair that area on its own. So you must have a skin graft, right? You can get a skin graft where they take some skin from another part of your body and they lay it over that area. Also, you know that if you have, let's think of any scrape you've had, and you know that wounds, large wounds, grow, they heal from the outside in. Right? You have a scab in the middle, but they get smaller and smaller and smaller as the skin moves in from the outside. But if you have a third-degree burn, you don't have that skin on the outside to grow in. So these wounds have to go through a lot of debridement. Debridement is basically cutting around the skin, causing it to regenerate. Very, very painful, extremely painful. And if it's bad enough, it would lead to amputation. So let's take a look at this again. In this picture, first-degree burn. First-degree burn, you are simply affecting a portion of the epidermis. In a second-degree burn, you're burning away the epidermis and a portion of the dermis. In a third-degree burn, you're destroying all of the skin. This is a full-thickness wound. First and second-degree burns are oftentimes called partial-thickness burns because they don't go all the way through. When your skin is repairing itself, it has to lay down collagen rather quickly, and that leads to a scar, right? Some sort of scar. Scar is simply a bunch of collagen that is being produced as the skin is repairing itself, and those fibroblasts are very, very busy regenerating the skin and the scar tissue. Sometimes that scarring process becomes overzealous, and overproduction of scar tissue is called a keloid. A keloid, and this is where you get a raised scar or a hypertrophic scar, and it's just a much, much thicker looking scar. I should also point out that when a scar is formed, a mature scar is not going to have those accessory glands. So wherever there is a scar, there is not going to be hair, there's not going to be sweat glands, there's not going to be sebaceous glands. So those accessory glands are not replaced when the skin is regenerated after some sort of damage. So that brings us to the end of this chapter. Oh, I should say just a couple interesting things as well related to your skin. And that is bed sores and stretch marks and calluses. Again, these are all things we've probably heard of. A bed sore is also called a decubitus ulcer. And these ulcers are not uncommon in individuals who are bedridden. So individuals who are in a hospital bed or a long-term care facility, it's very important that they are turned, that they don't just lay on certain parts of the body, because the skin gets thinner with age, and that thin skin can't handle all that constant pressure. So if you just lay on your butt all day and you don't get turned to your sides, then that blood flow can lose, that area can lose blood flow, and it can lead to tissue death. And these are very significant problems. And if a person gets bed sores, it is not exclusively, but oftentimes a sign that the person's not been cared for adequately. They've been neglected, and these bed sores can become infected and can be fatal in some individuals. Also, a stretch mark. We may all have stretch marks. Stretch marks are a result of the dermis being stretched beyond its elastic limits. Recall, the dermis has collagen and elastin in it. Places where you think about stretch marks, one would be during pregnancy. As the skin is stretched, it gets stretched beyond its ability to stretch back, and those collagen fibers sort of get ripped away from each other. The skin loses its strength a little bit, and you get that stretch mark either from a rapid weight gain, like during puberty, or during pregnancy. And then finally, any part of your skin that you are abrasing or getting roughed up on, for example, the heel of your shoe or the sole of your foot, or maybe if you're you work with your hands a lot, you might have calluses on your hands. This is simply an area where lots of cells are triggered to divide to make more cells. This is a protective mechanism, so the skin gets thicker in those areas. And you might have a callus or a corn, which is basically a specialized form of a callus. So calluses and corns, think stratum corneum, that thicker outer layer of the skin increases. And that does finally bring us to the end of this chapter on the integumentary system.